professor, assistant professor at public health at the USF, College of Public Health. I have some business cards up here if you need to get them for afterwards. I have a doctorate in public health, and my area of expertise, if I have one I suppose, is health insurance. Okay, so I do Medicare and Medicaid. Prior to academics, I was the director of a Medicaid managed care plan. And before that, I worked for a large HMO that did Medicare and Medicaid, where one of my policy areas was something called the dual eligible special needs plans, called D-SNPs. So I'll refer to that a lot. So the question of this presentation is, are special needs plans special? So with that in mind, I will explain Medicare, Medicaid, sort of how that connects with dual eligibles, right? Somebody that can have both Medicare and Medicaid. I'll talk about Medicare Advantage, which is a special private HMOs for Medicare that run these dual eligible special needs plans. The basic question of the presentation is, are they special? Do they offer anything that more than just regular Medicare or having Medicaid and Medicare together? And hopefully we'll get to the bottom of that.
Since he's filming you, you might want to fix your lapel. There you go.
Thank you very much.
That's
Appreciate
nice
that.
of him to tell you.
Yeah, no, it's good. How do I look? Everything good?
Good.
All right, thank you very much. Good. So, and you're welcome to interrupt me at any point. So I don't know what you guys know about health insurance. After doing it for 15 years, even though I teach students in healthcare administration and public health, I often forget what people know and what they don't know. You know, basics of health insurance and healthcare in general. So I'm happy to have you interrupt me and ask the basic questions. It's absolutely okay. Okay, great. So with that in mind, we'll go. So Medicare. Medicare is the federal health insurance program. That is, it's run through Washington, D.C. It's the same throughout the country. It's for those who are 65 and older or have disabilities. Of course, that's important for today. Those that get Social Security, come on in. Those that get Social Security disability insurance, after 2 years of waiting, of course, you become eligible for Medicare. That's a good thing. Medicare, however, has high out-of-pocket costs. That is, they have deductibles, they have co-insurance for inpatient stays, you have to pay a premium for outpatient, for doctor's services, so it's very expensive, especially if you're sick. Medicaid. Well, Medicaid is another type of government insurance. Of course, this one run jointly by the federal government and the state governments. Excuse me, for those taking notes. So state governments, there are 50 different Medicaid programs, right? So they're all different in some way. Is that good? You want me? So that means that the federal government has a separate program called Medicare, and the state governments have their separate health insurance program called Medicaid. They were both started in the 1960s, but they're very different. Medicaid provides medical coverage to those with low incomes, and those oftentimes can be from spending down or having lots of medical bills that make you low income in some way. There are 10 million children and adults who qualify for Medicaid based on some sort of disability. That's a lot. So qualifying for Medicaid. So states provide Medicaid to people who receive SSI benefits. They get those, they get it automatically. Low income and asset tests vary by states. So I said it's for low income folks. That is the case, but they have rules about who can qualify for Medicaid. In Florida, for example, the monthly income limit for Medicaid, $864. For a couple, about $1,100. And you have asset limits. That is, you can only have so much in assets, not including your house and your car, for example, and some other small benefits. But you can't have more assets than $5,000 for an individual and $6,000 for a couple. So there are some rules about what it means to be low income. Any questions so far? Okay. So I've presented Medicare and Medicaid, two different types of government insurances, and they're used widely by those with disabilities. And now I'll talk about what happens when you have both Medicaid and Medicare. That is, you qualify for SSI, and you may have gone through a waiting period, and now you're qualified for Medicare, right? You get Medicare federal insurance, but you're low income, so you have state health insurance as well. They're called dual eligibles. There are 37 million Medicare, 51 million Medicaid, and where they overlap, there are 9 million dual eligibles in the United States, covered by both. And that was in 2008, so there are even more now. But the problem is, it's very frustrating to have two different insurances, or sometimes three different insurances. You have some secondary insurance. So you have three different ID cards, one for Medicare, one for Medicaid, maybe a supplemental insurance of some sort. You then go to the doctor and they say, what's your insurance? You have to explain it, and it doesn't get qualified for Medicaid because Medicare is the primary. Very confusing, very frustrating. All right? And so oftentimes you have different people doing different types of services, and those providers rarely talk. Very frustrating. It's also expensive. So when the federal government and the state government are in the same business of providing insurance, they oftentimes have different incentives for controlling costs. For example, let's say, this is not really related to disabilities, but maybe it is. If you're the healthcare policy for insurance for nursing homes means that the state government, Medicaid, pays for the nursing homes. But the nursing homes the state has no incentive to keep them out of the hospitals because hospitals are paid for by Medicare, the federal government. So the nursing homes are like, well, let's just go ahead and send them to the emergency room and see if they get admitted. That's fine by us, because that's paid for by the other guys, right? So there's very little incentive for the nursing homes, for example, to coordinate care to keep them out of the hospitals. Okay? So what that sets up and has over the last 40 years is a terribly expensive, terribly frustrating health insurance program that's fragmented. So in the early 2000s, they started something for dual eligibles it's called dual eligible special needs plans. And essentially, this is a component that connects these two. Okay? This is real quick on dual eligibles. Medicaid programs help beneficiaries with out-of-pocket costs, right? So those who have Medicaid and Medicare, Medicaid offers a benefit to them by paying for all those hospital co-insurance, right? So the deductibles up to $1,000 plus, almost $1,200. Also for Part B, or some of the benefits. So if you're a Medicaid eligible individual, you get some coverage, which is great. And there's 350,000 Floridians that have dual eligible coverage. Right? So this is a recognized issue. Younger versus older dual eligibles. Of course, if you're a dual eligible, if you're elderly, 65 and older, and you have Medicare and Medicaid, oftentimes that's because you've been in a nursing home and you've spent down your income and your assets to now qualify for the state government to pay for your nursing home. But those who are younger often are disabled in some way and qualify for Medicaid and Medicare under their disability criteria. They also qualify because they have low income. But this is quite a different population, as you can imagine, than the elderly dual eligible. Those who are disabled are 2 times more likely to be reporting delayed medical, dental, or some sort of medical problems. Right? The system is not set up quite like it is for the older dual eligibles that have very similar needs. These disparate needs often cause delays in care. More of them lack usual source of care, like a regular doctor to go to, and they report gaps in insurance coverage. So in other words, they lose coverage and gain coverage through various mechanisms that causes barriers not finding the right insurance issued to cover their health services needs. Right? So they have a lot more trouble than older Americans, so that's why this is super important. Okay, it's just a real quick step back on Medicare. Medicare is a federal program, right? So the federal government runs it the same throughout. But during the early 2000s, they started, late 90s I suppose, they started something under the Bush era, George W. Bush, called Medicare Advantage. It essentially is these private companies that work for Medicare. About 20% of all Medicare beneficiaries are in this program called Medicare Advantage. Right? You may see these advertisements every now and again with these for-profit or health insurance, sometimes non-profit, big health insurance that offer the health insurance to Medicare enrollees, Medicare beneficiaries. It's called Medicare Advantage. So essentially the way that works is, let's take Aetna for example, right? They offer health insurance to those with Medicare, and what happens is the federal government pays them a per member per month fee to manage all the health care for that particular beneficiary. So like just lays on top essentially. Instead of going to the federal government, the doctors and the hospitals deal with the insurance company. That's called Medicare Advantage. Their incentive is to control costs and to improve quality. So they get bonused in the sense they get reports on how well they're doing managing their the patient's health care in terms of quality measurement. Did they get to the doctor on time? Did they control their diabetes? That sort of thing. Okay? They have incentives. But the question we have today, right, is about dual eligible special needs plans. The federal government, along with the states, recognize the trouble with managing these dual benefits, Medicare and Medicaid, at the same time, and said to these Medicare Advantage plans, these private insurance companies, we got an idea. We're going to start these special plans, and you're going to run these dual special needs plans, and you're going to help coordinate the benefits between Medicare and Medicaid. You're going to be responsible for case management, for helping the patients get to the right place, keep them out of the hospital, keep them on their drugs, do all the things that you're supposed to do as an insurance company, right? So you have these private companies, Aetna, United, WellCare, it goes on, offering these special needs plans. In 2015, 45 plans, and that should say 200,000 enrollees in Florida. Very popular, and it has been for a long time. But the question we're asking today, and I thought it'd be helpful to explain some of the literature on the research on dual eligible special needs plans, is do they work like they're supposed to? Do they have increased quality? Are they cost savings? Do they help the patient in the end? Well, the jury's out. Early evidence, one research said, on the quality of care provided to special needs plans, and then another Government Accountability Office, GAO, report on these that I thought I'd share with you guys. First, early results were not promising. So they set up these structures where the private healthcare companies in Medicare Advantage were supposed to organize the care beyond what they do for normal patients. And what they found was not so much. There wasn't really any difference between the regular Medicare Advantage plans and those that were supposed to coordinate the benefits, have case management involvement, ensure that they get the right durable medical equipment, all those functions. So this research, in fact, says early on, can't really tell the difference. The GAO report looked at it and said, you know what, these D-SNPs, they don't really coordinate with the state, that is the Medicaid agencies, the way they should. There's no real functional coordination between the Medicare benefits, right? Because these insurance companies get paid by Medicare, and the benefits offered by the state. The state was like, that's really complicated. We don't want to mess with it. So then they're back to the same thing, where they have Medicare benefits and they have to worry about getting insurance, Medicaid coverage otherwise. Right? So there really was no coordination. Only 1 out of 5 provided active care coordination between the D-SNPs and Medicaid agencies. So the benefits are not the same, right? You have some benefits that you get through Medicare, you have some benefits that you get through Medicaid, and they don't always overlap, right? You get extra stuff in Medicaid, and you get extra stuff in Medicare. And who knows what you get. And it gets even more complicated, probably not for today, but are you a full dual eligible Medicaid recipient? Are you partially dual? Do you get drugs covered, inpatient, outpatient? I mean, it's very complicated. And these private plans did not make any effort to coordinate with the states like they were supposed to. Well, they said, that's the value we're bringing. They hoped it would work. It just never got to that. Okay, so the answer is not so much to the main question, at least early on. So what the federal government did in a series of laws is create, and regulations, is to create rules for these dual eligible special needs plans that they actually coordinate care with the states. They have contracts with the states that provide these Medicaid insurance, and that they have really robust care coordination, case management functions called models of care that they work with their patients. So no longer could they just call themselves a dual eligible special needs plan. There had to be some actual substance to what they were offering, not just the name. All right? And they had to, as I say here, they had to contract with the state Medicaid agency in a very detailed way about what benefits, what was covered between the both, right? So we have both, it's very complicated. Now these contracts spell out specifically. In the state of Florida, in fact, the state Medicaid agency pays these private healthcare insurance companies that run the D-SNPs a small, per member, per month, small fee to manage the benefits within them at the state level. So these D-SNPs are getting not only paid from the federal government, or per member, per month basis, they're also getting paid by the state government. And their responsibility is to deliver those through one company, as opposed to before it was all fragmented and frustrated and super expensive. Right, that's what I just said. Great, they make capitated payments. Capitated, anybody know what that means? You can talk the lingo. Yes? All right. Capitated, like decapitated, right? Per head, essentially. Okay, that's important in health insurance, right? So, because their incentive is to control costs, to keep costs down. If they're getting only a certain amount per member, then it's important they do that. Okay. Well, let's talk about the model of care. So the rules and regulations, the new ones. Remember, we got results back that said, nah, they're not doing so great. I mean, they're not even any better, really, than the other Medicare Advantage plans. So now they're required to have these models of care. And so what do? They're supposed to have an interdisciplinary care teams, right? Social worker, RN case manager. They have the medical director, behavioral health medical director. You'll have health coaches. You have life coaches. Just depends. It has a very, it's pretty open, and we're still working on in the healthcare industry about what that interdisciplinary team construct is, but that's what they do. You're supposed to develop individualized care plans. Integrate behavioral health, medical care, pharmacy, all in the same way. Okay? You have to be very detailed about how that is handled. And then finally, NCQA, or National Committee for Quality Assurance, which also approves hospitals. They measure health quality for managed care. So it's a nonprofit organization made up of the community of healthcare professionals that whose aim is to have improved quality of care. And so now these D-SNPs have to send in their model of care to NCQA to get approved. And it's no longer just some policy analyst writing up what he thinks sounds good. They go in and audit to make sure there is a there. Okay? Any questions so far? It's complicated stuff, so. Okay.
One quick question.
Yes, ma'am.
You enroll into a dual SNAP, and you need a power wheelchair. That's a good example that you need.
Yes.
Medicare will provide you a modifications you may need. Therefore, Medicaid will pay for it, but because Medicare will cover it and give you the lesser value on it, you get that.
Right. So this is the idea of where D-SNPs would be preferred, right? Because they get paid in Florida at least, right? In many other states, they get paid a per member per month fee to manage the benefits of both. No longer is that conflict. Should that conflict be there? But managed care, being managed care, often wants to say no to things. So it's not like it's a panacea of, oh my gosh, now I've got D-SNPs and it changes everything. But it can provide to you one contact, so to speak, to make the case that the wheelchair that was covered, the standard wheelchair, needs to be modified for improved quality of life. You can make that argument, they should approve it. As opposed to, well, you're going to have to call them, now you got one person to go to.
But what about if that person is not willing to continue doing what your needs are, because she's saying, no, this is what Medicare is going to cover, this is what you're going to get.
Well, they don't necessarily have to follow what Medicare says, right? They can do anything they want, right? No, I'm not saying they won't.
Yeah, let them know that, because they don't know.
Well, and then managed care has, appeal functions, right? So you can appeal a particular decision. I'm not saying it's going to happen, but that's the mechanism. The idea, at least, is that you're putting them both together to have one contact for that, as opposed to, I don't know, just go ask somebody else. That's the idea. Okay. Very good question. Okay. So there was a study after these regulations were put into effect. It's called the Brand New Day study. It's actually a health plan. It's a dual eligible special needs plan. This one is specifically for those with severe mental illness. It's just a specific type of chronic disease, if you will, dual eligible special needs plan. They looked at it and they saw they have a bunch of outcomes like staying out of the emergency room, staying on your drugs, staying out of the hospital, not being readmitted to the hospital. These are all very standard health administration or health services outcomes. The overall results were mixed. That is, the functions, the care management interventions provided by a Brand New Day were both good and not effective, depending on what the intervention was and what the outcome was. But there was some good news. Added depression screenings reduced emergency department visits. So the case manager calling and saying, we're going to do another depression screen, how are you feeling? There's a standard format for that screening. They did it more often, more touches, kept them out of the emergency room. Seems to make sense. Medication review by the PCP reduced emergency department visits. So the PCP stands for primary care physician. So your doctor, your regular doctor you go to for checkups. This was a good thing, making sure that the medications weren't causing any problems and sending them to the emergency department. Makes sense. And they had life coaches. Brand New Day had life coaches that reduced hospital readmissions. Now there were 8 other types of interventions that did not work so well. And oftentimes when you, in science, doesn't mean there wasn't an effect. You just couldn't measure it necessarily. But a Brand New Day really has a sophisticated model of care or a specific way of doing care management. And they were testing whether it worked. And it sort of did. Sort of did. They also did an assessment. AARP has a policy arm. They looked into the value of Medicare Advantage D-SNPs in a study called Care Management Practice in Integrated Care Models for Dual Eligibles. Academics love their good pithy sayings, right? That's a good one. They did a good job, though, of reviewing 4 different Medicare Advantage special needs plans for what they did in care management. How is it different? What's special about it, if you will? Well, what they found was that all of them had home visits. Send case managers to home to figure out the environment in which the patient lives, and give them the needed things that they have. They get paid a per member per month, They can get services they may not be able to get through straight Medicaid because they're trying to keep the patient healthy and get good quality scores. The team approach. All of these plans had a way of approaching care that wasn't just, you have a doctor here and a doctor there, and you have to then do all the communicating between the two yourself. This had an interdisciplinary team, as I mentioned before, of social workers, of case managers, of pharmacy review, pharmacists, behavioral health specialists, and the like. Many touches. The patients were proactively reached out to through email, phone, home visits, as I mentioned. The idea was that the more touches they had, the better health outcomes in terms of reduced hospitalizations, reduced emergency stays. That's sort of what their job is, right? That's what the law said. Hey, D-SNP, you're supposed to have this really robust model of care. And what this is reflecting is certain plans have implemented it in a good way. Focus on transitions of care, right? If a patient does get admitted into the hospital, how do we get them from the hospital to a skilled nursing facility or to home and then stay out of the hospital? So they really focused on those transitions between one care type to another. As I mentioned, fragmentation is very, very important. It's really a big problem, so this tried to stop that. And then supporting care managers with information technology. The idea is that all they have phones and computers. When they go in the home, they can then make orders or put in the notes. They were supporting the infrastructure for communication between different types of providers. Again, the whole idea, at least according to AARPs Policy Arm and evaluating these 4 plans, is the idea is that they're just trying to connect the puzzle pieces. We're very, very fragmented in this country. I don't have to tell you this, but primary care, medical management, behavioral health, member services, support services of various types are often not connected. The idea, at least in theory, is to connect all these around informal supports and family for the patients. And that's their primary job. So let's go look at an example. This is a Mercy Care Advantage. They're a dual SNP plan in Arizona. I'd never heard of them before I'd done this. I've not lived in Arizona, so I don't know. But I do know they did a comprehensive evaluation or assessment of what sort of services they offer. And here's what we found. Yes, initial health risk assessment, an HRA. So when you first enroll in this dual special needs plan for Medicare Advantage, they'll do a review, an assessment when you first roll in. So what's your cognitive function? Set the baseline. Are you a fall risk? Do you need special durable medical equipment? All right. What are your medications? Do all that individualized. The next step is individualized care plan with the case manager saying, okay, here are the next steps. What are all the, who's the PCP, who's the primary care, whether it's, internal medicine, maybe it's a specialist of some sort that acts as the primary care physician. Who is that? Establish the care plan with that PCP. And then, of course, case manager. Depending on the plan, Mercy had a 1 nurse to 55 patient caseload, meaning that they had 55 patients that they had to deal with, right? Could be more, could be less in different companies. I think 100 is probably what you would see in normal circumstances across the country. Of course, the case manager would be introduced, and then there would be a connection with the PCP, according to this report. Who is the interdisciplinary team? As I mentioned, the care management coordinator, usually an RN. If they're not an RN, they're sometimes an MA or a specialist or a medical assistant with the management of a registered nurse. So it just depends on the model. A social worker, a clinical pharmacist, and of course as needed, so when you want to appeal or want to discuss to the health plan medical director or the behavioral health medical director, they're required to do that, and they have to sign off on various appeals or reviews and that sort of thing. And then of course, they work in conjunction with the primary care physician. Internal medicine, that sort of thing could be it, but it could be another type of physician as well. Yeah, go ahead.
Maybe I'm a little confused on what I thought this was going to be. It says dual, where is it? I can't say, dual eligible special needs plans, special. Dual eligible means you're eligible eligible for Medicare and Medicaid?
Yes?
Okay. Do they, from where I know it, they never come together. So it's.
That's the great thing about this.
But I mean, so are you telling me the only way to make it work is to join a, PPO?
Oh, well, yeah, that's right. It's not really a PPO, but yeah, there are these private companies, Medicare Advantage. Right? So it's up to you. I mean, they're supposed to, through federal government law and regulation, to coordinate the benefits between both. In Florida, these private companies get federal dollars, they get state dollars to integrate the benefits by law. And so the question was, now you seem dubious, that's fine. I used to work at a managed care company. It wasn't a great experience. So I'm not here to tell you that I love private, for-profit health insurance companies. That's not the message here. It's a policy message that you have this available to you. Now working, for a university, and I don't have any affiliation with any of those. But that is the idea. We live in the United States. This is not a country where all the health insurance benefits are under one umbrella. We are super fragmented. And so this is an effort, a policy effort to connect them.
What I've seen though, since what Florida's done with these plans though, they've really watered down Medicaid much more. So, and to me that's discriminatory. And I don't know who to take that to, I guess my federal people, but the bottom line is, most of the PPOs have, just for instance, over-the-counter formulary. Medicaid is almost non-existent. Nothing. Medicaid in Florida, in my county, only has 2 health clinics, dental clinics. And they don't use what I call best practices for special needs people of mild tranquilizers or nitrous oxide for dental practices. And that's my only choice. So it's almost like they're saying, well, you have a choice, but they make it so bad, the product's so bad, you're looking at, well, what else is there? That's pretty bad.
Pretty bad, I agree. All right, so Medicare does not offer dental benefits. Medicaid offers dental benefits, right? So,
Very good.
well, I mean, they do more than Medicare. Can you agree with that statement? Okay. And so the idea is that you're going to one plan to do both. I want my dental benefits. I have a case manager that says, look, I can't have a high quality of life if my teeth hurt. You need to help me. You're the one person, you're paid to do it, that sort of thing, right? I can go then talk to my state senator remember the states oversee Medicaid, and say, you have a contract with the state of Florida and you're violating it. So call my senator and say, talk to WellCare, talk to Amerigroup, talk to, right? So now instead of call them and say just the state government has a problem, there's additional line of accountability when you can have one contact, in my opinion. And that's the idea, is that you're integrating these benefits. Okay? Trying to explain one benefit for Mercy. Again, they're in Arizona, but this is a good example. If you are admitted to a hospital, the case manager works closely with the RN as a transitions coordinator for discharge planning. Oftentimes that is a big step that gets messed up somehow. When you leave the hospital, you don't have all the information you might need to stay out of the hospital permanently, right? Well, Mercy has a welcome home program. The idea is that they reduce the chance of readmission, ensure the compliance with the plans, and improve communication with PCP, provide support for non-medical issues. All these things seem so basic that you can't believe they're not done already. They're not done. But case manager would be the person to contact with this plan. Your case manager. So if you were interested in Medicare Advantage dual eligible special needs plans, those that are required under law to coordinate both Medicare and Medicaid benefits, you can go to the Medicare Plan Finder, which is on the web. Go to Google and search for a personalized search or a general search for these plans. Right? That will tell you who has Medicare Advantage, these private plans that contract with both the federal government and the state government. Right? before you sign up, you can say, what is your model of care? What does that mean? Describe it to me. I have special needs. My family member has special needs. How does that fit? What are examples of your benefit flexibility? Medicare offers this kind of wheelchair. Medicaid says they won't. How much flexibility will you have to keep us healthy and happy? What is your patient to case manager ratio? Great, I have a case manager. How many other people? How can I get a hold of you? How long do your PCPs partner with your plan? Do you have a stable network of primary care physicians? Or are you going to they're just going to switch every month? I'm going to have to go to a new one. And do you have enough blank specialists in your network? You know, I have needs for an orthopedic surgeon. I need to know if that's in the network. How do I manage that?
Right.
Okay. And there are lots of them in the state of Florida. There were 45, as I mentioned before. They're all big companies that you may be familiar with. United Healthcare, you know these names, Cigna. There's some other players. WellCare it's based in Tampa. Molina and Coventry are small companies that deal exclusively in government services, and Simply is a very similar plan to that. Blue Cross Blue Shield. There are dozens. So it's just about getting the right benefits and premiums and asking friends that have this special needs plans whether they're responsive to your needs. Okay. Yeah, bring it. Love it.
Would this work for any age? For instance, we know for a fact that some children under the age of 21 will occur Medicare due to their parents retired and they have special needs and they already have Medicaid, so that's aside.
Right.
So therefore they get the Medicare.
Right.
Would this really work for them, this SNAP? Because honestly,
None of it works. I don't know what to tell you.
I think I'm still going to be the case manager that's just going to continue doing what I'm doing and
You can do
fight
that.
whichever one of them.
That's fine.
Because it seems like
Yeah.
it's more complication for them, and especially now since we have a special need population that do also have Medicaid waiver.
Yeah.
So that's a third insurance that we have to deal with.
That's right. Yeah, you're right.
And maybe a fourth one if they still have a private insurance due to one of the parents who are still working somewhere where they have insurance.
I don't know what to tell you. They have additional services. By law, they have to offer a model of care. They have to have a sufficient network. They have to have a specific care manager assigned to you. They are accountable in their measurement of their quality, and that includes patient satisfaction. They have your congressperson will know what that is. Your representative at the Florida House and the Senate will know what that is. There is accountability. They are a for-profit company, all of them, most of them in the state of Florida, right?
Right.
So their incentive is to restrict care, but they're also incentivized to have higher quality, and you have one case manager. Can I tell you, is it going to be less frustrating? I don't know. It's an option. It's still frustrating, right? There's sort of a minimum level of frustration in our healthcare system if you need healthcare. If you don't need healthcare, great healthcare system.
Frustrating part is not getting the proper equipment. Let's say diapers. Great example.
Right.
Medicare will give you this type of diapers, but then your patient really needs this type of diapers.
That's right.
Maybe this one contains Medicare or contains latex, or Medicaid does not contain latex. And it's
It's
just,
supposed to be integrated. Whether it is or not, over the last 5 years of improvement, I can't tell you. It's an option. Yes?
So then what are the disadvantages to signing on to the Advantage plans?
They can switch you from your current doctors to different doctors. They restrict their doctors.
Wow.
Right? So just like I'm familiar with health insurance, right, where they have their network of providers, and your doctor may not be in that. Oftentimes it is, but it may not. You'd have to check. You may have your doctors you like. Medicare offers supreme flexibility in terms. Most doctors take Medicare, right? Good deal. but they might not do this to the private companies, right? Remember, only 20% of Medicare beneficiaries go to these Medicare Advantage plans. But again, it's about that integration and the care management, additional care management you
No,
don't
I
get.
heard there might, I don't know if it's true, maybe you can help me. Somebody told me that if we were to sign on to the Advantage plan, because we have Medicare and Medicaid. Right now, from my understanding, we don't have like a limit on spending of what we use. And I heard
Right.
if we go to Advantage, so if my son gets a transplant, that will just blow all his money in the Advantage plan and that's it.
No, I don't think that's on federal law. I don't think they have those limits like that.
There's no limits
No.
through Advantage.
I don't think so. No, there's Obamacare covered that, lifetime limits and that sort of thing.
Okay.
Because there was a policy change. It's not, those really expensive patients aren't the big deal. It's the stuff in the middle that's so expensive. And so the federal government, as a policy, through Obamacare, said, let's not do this anymore to our consumers. Let's not have medical bankruptcies. Let's really cover people. That's a good question.
Another thing is somebody told me through the foundation, my son can only get Pulmozyme, cystic fibrosis, once a day through regular Medicare, Medicaid, whatever, but no Medicare. When we had Medicaid, we were able to get it twice a day. But they said if we were to sign on to Advantage, we can go back to twice a day. Why?
I don't know why.
I don't
It's
understand.
probably about benefit flexibility, right? So what they want to do is keep your son or daughter, son out of the hospital. And so that's what's called that benefit flexibility. So when you're running Medicare, you have to sort of standardize care across the board to sort of manage the huge program that it is. With Medicare Advantage, you have a little bit more flexibility for right care, right place, right time.
Now, in
That's
my
in theory.
situation, would you recommend going to Advantage plan or not?
I would recommend looking into it. And it depends. I would ask around if your friends have it for these particular
Not many
services.
people have it because of the age.
I think it's a benefit for having a case manager, someone to call to go to, for the integration of the benefits. I also prefer the accountability, to make a big stink about not getting what you need and having a process by which you can appeal and then get, your congressperson or your.
Wouldn't we have that now with straight Medicare and Medicaid?
You don't as much, right? Because then that goes into Medicare, which covers millions and millions of people. Less accountability because they have their set benefit structure. It is a little bit more accountability. On the other hand, there are private companies that are difficult sometimes to deal with. But it does. The idea, at least at a policy level, is that you're integrating both Medicare and Medicaid, so that you can do things like get 2 a day when Medicare said, no, you just get 1.
But then I would worry about, like you said, changing doctors.
Yeah.
Special doctors.
So you call your doctor first, say, do you take any Medicare Advantage? Okay, that would be a key. Which one do you take? Unless you're not committed to that doctor, then it's fine. And you can also go into the you can go and call the company, call United and say, do you take this doctor in this county? Yes?
You commented early on how fragmented we are nationwide now.
Yeah.
Do you see that, in your study and information do you see what you think that would look like in years to come or something?
Yeah, we're getting better. It's still terrible. But a lot of smart people are working on it. This is part of that, right? Okay, we have a fragment. What policy are we going to bring to bear on it? Is the policy working? Oh, no. We better do something. We change it. And having millions more insured helps that process, right? So the Affordable Care Act is a big deal, and it has helped. But it did add a layer of complexity again. But I think, yes, we're getting better. Will it ever be that of Canada, where it has a single payer? No. It will always be much more hodgepodge. But give and take. Question? No? You good?
No, thank you for bringing the subject up.
Sure.
I've been to these conferences for years and we even discuss some really
Okay.
fun
Well,
things.
I'll have you're welcome to come up after, and then I have business cards if you can take if you have questions. I can always point you the right direction. Okay, thank you very much.
Thank you.
Thank you.
Yeah.